thoracic pedicle screw is important because there is slightly different anatomy. Second one is you are working around the cord. Third is there are very important structures anterior and lateral to the pedicle also. Unlike in lumbar spine where lateral penetration is not a big issue, here you may injure some vital organs. So the most important issue in thoracic pedicle screw is the anatomical consideration. As because I told us, after exposure, you have to have this an open thoracic pedicle screw. You have to consider 4 important anatomical issues. One is the transverse pedicle angle, that is the angle between the entry point and into the body. The transverse width, which is this point between D and E, that is the width of the pedicle. The cord length, which is A and C, which is the entry point to the tip of the screw length, or the second thing is the screw length, starting point, and the insertion techniques. These are the considerations we'll have while doing thoracic pedicle screw. The entry point and other things is slightly different from lumbar pedicle screw. So as I told you, the transverse pedicle angle, which is an angle between the transverse midline to the pedicle, is widest at T1 and the narrowest at T12. In fact, in T12, sometimes you can even have a negative of 5 degrees rather than a positive angle converging inward. So you should be aware of these angles when you start inserting the pedicle. So as I told you, the transverse width, the second important point is transverse width of the pedicle, so that the size of screw to be inserted. So the diameter of the screw normally in adult population is 5.5 in the upper thoracic spine. Below D9, D10, I tend to use 6.5. I do not use 4.5s even in the upper thoracic spine because there is a slight give way of the pedicle, and then you can safely put in a 5.5 screw in these. So we should be aware that the transverse width is the least at T4 and the widest at T12. As we go up from T4, T3, T2 and T1 are wider and easier to insert, and the angle of insertion is much wider, that's nearly 25 degrees. The thoracic pedicle screw fixation techniques is, there are 2 techniques. One is an anatomical insertion technique described by C. also et al. And then the direct insertion technique described by Lenke et al. In the sagittal plane, if you see, the angle of insertion from T1 to T12 increases from 10 degrees to 15 degrees. That is a cephalocaudal angle or a superior-inferior angle of 10 degrees to 15 degrees, as described by Professor Jaiswal's paper in 2004. And in the European population, they have described it as 12 degrees to 16 degrees, as seen in this paper from Zenrik et al. There are 2 techniques of insertion. One is a freehand techniques. The second one will be image guidance. That will be like lateral and anterior fluoroscopy. The freehand technique requires meticulous exposure. We require cortical bursts and pedicle palpation seekers. So these are the important entry points as we have marked in this picture, as you can see, from T1 to T7. And then the point moves slightly inferior and slightly medial from T8 to T12. The point is in the upper end of the transverse process, where the transverse process meets the lamina from T1 to T7, where the superior facet, transverse process and the lamina meet, and from T8 to T12, it is it's slightly inferior to that point and medially placed. In the exposure in an open thoracic pedicle screw should be to expose till the tip of transverse process. Remove the inferior facet if you are going to do a fusion. If you're not going to do fusion, you don't have to remove the inferior facet, and scrape out the cartilage on the superior facet if you're doing fusion. Use a cortical burr, a small 2 millimeter burr to start the starting point. It can be, you can see in this in this picture where the starting point is. It's the junction between, as I said, T1, T2, junction between bisected transverse process and lamina. Then in the mid-thoracic, that is T7 and T9, it should be more medial starting point, junction between the proximal edge of the transfer process in the lamina and where the lamina meets the superior facet. In the lower thoracic, it's junction, it's T9, 10, T11, and 12. It's a junction between the bisected transverse process and the lamina, and slightly medially placed. So the most commonly used technique is a gear shifting technique as described by Lenke. I think it was previously described by C also. C also uses a drill, hand drill or a mechanized drill, and then he probes the pedicle. Lenke uses gear shift technique. So the thoracic gear shift is once you probe and see the pedicle blush, you start with this gear shift with the concave side facing the convex side facing the medial wall, so that you hit the medial wall and skive into the pedicle. And once you're through to the pedicle, then you turn the probe medially so that the concave side faces medially now after inserting 15-20 millimeters, and then get into the pedicle. Once you're thorough, then use a feeler, a thin feeler as you can see here with a ball tip. So use a flexible ball tip pedicle sound which can probe all the walls. You should have 5 bony endpoints. That's the anterior endpoint in the vertebral body, the superior and inferior pedicle walls, the medial and the lateral pedicle walls. Once you're sure of it, you can actually tap the initial part of the screw. I usually use a smaller tap if I'm putting a 5.5 or a 6.5. I usually use a 4.5 tap and then insert a screw. Once you tap, it is easier. You can actually repalpate using the same tip, the flexible pedicle probes, and then you do the screw dropping. This can prevent inadvertent, this is a freehand technique, so inadvertent penetration of the medial wall, which is more dangerous because you are working near the cord. So as I said, these are the few steps. So you see a pedicle blush and then use the probe inside, tap. Usually I use a 4.5 to tap and then put a 5.5 or 6.5 screw. The more challenging pedicle screws in thoracic spine will be in the deformed scoliotic spine. It is feasible, but you should have much more morphometric knowledge of the scoliotic pedicles. So the pedicle orientation is totally different. The pedicles may be in a wind step. The problem in scoliotic spine will be the shift of dural sac towards concavity. There will be thin pedicles on the concavity. The pedicle width on concavity may be almost not there. You may not even have a pedicle there. No differences in pedicle length or cord length between concave and concave side. Usually once you insert in a proper technique, the cord length, that is the length of the screw, does not vary very much. So concave pedicle is usually thinner and shorter, as I said. The spinal canal smaller on the concave side and spinal cord is shifted. So you have to be very aware to not to injure the cord. And as now we use IONM, and we use IONM screw stimulations, which actually prevents all these issues. The other problem is a windswept deformity of the pedicles in the thoracic spine. It's called windswipe, described by O'Brien et al., where one of the pedicle, both the pedicles are in the same direction rather than, so you actually have to insert both the screws in the same direction rather than in a converging direction. So screw fixation in some of these cases may not be possible at all, because the length on the convex side will be much more, and you will have a medial penetration whichever way you try to insert the screw. So that's a problem. You can use an out-in-out, in technique in such situations. So the other technique of screw insertion for thoracic pedicle is better guidance with a 2-dimensional navigation. A 3-dimensional, if you have model and you can even have an intraoperative CT scan with a 3-dimensional navigation. And in difficult situations, we study the thoracic pedicle if it is very thin, and if it's uncertain intraoperative pedicle orientation, you can do an open laminotomy, palpate the thoracic pedicle, and then insert. In the most commonly other used technique is the in-out-in technique, where we use the pedicle and the rib as a single unit. So the screw goes into the transverse process, enters the lateral wall of the pedicle. It goes in between the rib and the pedicle as seen here. And then usually there is a wider distance of the pedicle. If the pedicle is quite narrow, you have a wider width available now. So you can, and the screw actually has around 80% of the pull out strength of a pedicle screw. So you can easily put in a 5.5, sometimes even a 6.5 screw. Thank you.